all these four muscles provide dynamic stability to the glenohumeral joint. And it is important in both coronal as well as the transverse plane. Coronal plane, the ITS, which is the infraspinatus, teres minor, and supraspinatus, they balance the superior movement arm created by the deltoid, which I'll describe later. And in the transverse plane, the subscapularis balance the posterior movement arm created by the infraspinatus and also teres minor. And together they are supplied by multiple arteries, which originate from axillary artery as well as subclavian. The subscapular and also humeral circumflex artery originate from axillary artery, and suprascapular originate from the subclavian artery. And in order to understand the function of these rotator cuff muscles, you need to understand two principles, namely the force coupling and also the suspensory cable system. So first of all, describe on the force coupling principle. So in coronal view, there is a movement arm created by the deltoid muscle, which pull the proximal humerus upwards. And this is balanced by the rotator cuff muscles, which counteract on this movement arm. And this balance are provided by the ITS, infraspinatus, teres minor, as well as the subscapularis. Whereas in transverse plane, it is divided into anterior and posterior. And the anterior is stabilized by the subscapularis, whereas posterior is stabilized by the infraspinatus and teres minor, IT. So together they provide a stable force coupling in coronal as well as the transverse view. The next principle is the suspensory cable system. So if you see the axial view as well as the coronal view, you can see there is a crescent shape here, the B, label B area. This is the rotator crescent, and it is a thin crescent shape of the distal portion of the supraspinatus and infraspinatus. And proximal to it, the C area, this is the rotator cable, and it is the thick bundle of fibers at the avascular zone of coracohumerus ligament. And the most important thing here is the cable, because all these cable formed by the supraspinatus and infraspinatus, they act as a suspensory ligament to provide stability to the glenohumeral joint. So the most important thing is the rotator cable is the most important structures as compared to rotator crescent, which provide minimal support to the glenohumeral joint. So this is important because we need to know the location of the tear will affect the plan of our treatment. So if the tear is affecting the rotator cable, we need to do an active intervention. Whereas if the tear is located at the rotator crescent, we can treat it conservatively. So like I mentioned just now, intact cable system and intact force couples in both transverse and coronal plane is important to maintain the stability of the glenohumeral joint. And even though they may be anatomically deficient, that means there is a tear, but they may still be biomechanically intact, depending on the location of the tear. And the location of the tear is more crucial than the size of the tear. And tear involving rotator cable is biomechanically more significant than a tear involving a rotator crescent. So the intervention of repair should be done to restore both the rotator cable as well as to restore the force coupling. So rotator cuff tear is a stage where there's a continuum disease progression, starting from impingement to calcified tendinitis, then proceed to rotator cuff tear, subsequently proceed to arthropathy, and finally become a pseudo-paralysis. So in order to classify the rotator cuff tear, you need to stage it and grade it. So one of the thing you need to mention is the histological area. And the histological area of the rotator cuff is divided into 5 layers. The most important one is the between the stage 2 and stage 3, because these are where the blood supply originates from. And the other thing you need to understand is the dorsal side is more vascular than the articular side. Hence, most tear from the rotator cuff are originate from the articular side because it's less vascular. And the type of tears can be divided into articular side and dorsal side, as well as the intrinsic. And the articular side mostly caused by dislocation or fall, especially on the subscapularis area, and also in athletes such as baseball athletes, where they involve a lot of throwing mechanism. And for dorsal side tear, this type of tear normally occurs in those elderly population where they have a chronic degenerative tear and also impingement. Okay. Then the anatomically wise, most of the tear happens in the supraspinatus, infraspinatus, as well as teres minor. And they are caused by the degenerative tear in elderly. And it can also happen in shoulder dislocation in young adult. For subscapularis, normally they are caused by subcoracoid impingement and impingement where they fall in a hyperabduction and external rotation. And it can be also iatrogenic, especially during the shoulder arthroscopy. Next, we need to determine the size of the tear. The size of the tear can be divided into complete tear as well as partial tear. The complete tear is divided by D Oreo into small, medium, large, and massive. The size of the tear is important because it will determine our plan of management. For massive tear, most of the time we need to do a tendon transfer, whereas for small and medium tear, we can still do a repair. Whereas for partial tear, it can be divided into grade 1, grade 2, and grade 3, which is less than 3 mm, 3 to 6 mm, or more than 6 mm, or depending on the percentage of thickness, 25%, 50%, or more than 50%. And the other one is the location, articular site, dorsal site, or intratendinous site, ABC. Next, we need to grade the rotator cuff muscle quality. So this is graded by the Gautalia classification. Initially, in 1994, Gautalia uses the CT scan to grade the fatty degeneration of the calf muscle. However, nowadays, most of the time we use the MRI to grade the fatty degeneration. So it's staged from 0 to 4, where 0 is normal muscle, 1 streaks of fatty tissue, and stage 2 is less than 50% fatty tissue, and stage 3 is up to 50%, and stage 4 is more than 50%. So this is important because for the more the fatty tissue the more the fatty tissue is inside the muscle quality is less, and hence there is a higher risk of re-tear after the repair. And next is the Pate classification, where they classify the calf tear retraction in the frontal plane. So the first stage is close to the bony insertion. Second stage is at the level of humeral head, and third stage is at the glenoid level. Okay. So for rotator cuff injury, most of the patient, they have insidious onset of pain, and sometimes it may exacerbated by overhead activities such as combing the hair. And also they will complain of deltoid region pain, and also weakness and reduced shoulder range of movement, especially abduction. So for examination, we need to examine each rotator cuff, supraspinatus, infraspinatus, teres minor, and also the subscapularis. And the investigation, you need to do plain X-ray to rule out any bony avulsion fracture, as well as to look for any calcification. And ultrasound can look for any bursitis, and the gold standard is still MRI lah, where you can identify all the rotator cuff muscles. Treatment-wise, it can be divided into conservative as well as surgical intervention. For those patients with partial supraspinatus, infraspinatus tear, you can treat it conservatively, provided that the rotator cuff suspensory cable is intact, as well as the force coupling is still intact. And when the patient have asymptomatic full thickness supraspinatus or infraspinatus, you can also treat conservatively. And for those patients who are elderly, who are not suitable for surgery, as well as patients who are not compliant to post-op rehabilitation, it is wise not to embark on surgical intervention. Whereas for patient with subscapularis tear, like we mentioned just now, in transverse position, when the subscapularis is torn, there is a deviation of the force coupling, where the posterior infraspinatus and also teres minor are pulling more. So you need to do surgery to repair the subscapularis to restore back the force coupling. And when the patient have full thickness symptomatic supraspinatus or infraspinatus tear, you also need to repair it, especially for those who are involving the rotator cuff cable. And in cases where there is no improvement, even with conservative management, you can do scope and also try to repair the rotator cuff. For conservative management, the main aim is to avoid overhead activities and let it heal on its own. And you can do strengthening exercise once swelling and pain subsided. For example, the rotator cuff and also scapular stabilizer strengthening. And also, you can give steroid injection to reduce the swelling and improve the pain. As for surgery, depending on the grading, can be divided into low grade, high grade, and also massive tear. For low grade, grade 1, grade 2 articular site tear, the main surgery is the debridement, the subacromial decompression. Whereas for high grade partial tear or complete tear, you can do the repair in situ or conversion repair. And like I mentioned initially, massive tear, you need to do tendon transfer. And depending on which rotator cuff is torn, for the subscapularis tear, you need to do pectoralis major transfer. Whereas for supraspinatus and infraspinatus tear, normally we perform latissimus dorsi transfer. And those patients with massive tear and also glenohumeral osteoarthritis but intact deltoid, we do a reverse shoulder arthroplasty. So for arthroscopic repair, there are multiple techniques. One of it is margin convergence. So if you see the pictures here, there's a U-shaped defect on the supraspinatus and infraspinatus. The margin convergence is to reduce the strain on both lateral margin of the U-shaped tear, where we repair both infraspinatus and supraspinatus together and anchor it at the rotator castration. Whereas anterior, the other one is interval slide. The interval slide can be divided into anterior interval slide as well as posterior interval slide. The anterior interval slide, you release the supraspinatus from the rotator interval, and this can increase the mobility of the supraspinatus to be fixed to the lateral footprint. Whereas the posterior interval slide, also you release the supraspinatus from the infraspinatus to mobilize it to be fixed to the lateral footprint. And lastly, the subscapularis repair. Subscapularis repair is best operated in an arthroscopic repair fashion compared to open, as it provide better outcome. And also need to stabilize the biceps tendon with tenodesis. So arthroscopically, the superior lateral margin of the subscapularis is identified by the comma sign on the right picture here, which is demarcated by the blue arrow. Okay. Next is the long head of biceps tendon repair. So studies have shown that tenotomy and tenodesis have both similar functional outcomes. So it doesn't matter whether you do a tenotomy or tenodesis. But the most important is to restore the footprint. The next is the restoration of footprint. Restoration of the footprint for rotator cuff, it can be divided into double row and single row. And studies have shown that the double row provide a better outcome in terms of retear rate. That means there's a less chance of retear in double row compared to single row. However, it requires a prolonged surgery and require a higher skill. Otherwise, functionally, double row and single row, they are almost the same, and also the functional outcome is the same. And coracoacromial ligament release is also indicated sometimes when you want to release it to increase the anterior and inferior translation of glenohumeral joint to improve the subacromial space. So this is the study where they compare the single row versus double row arthroscopic rotator cuff repair. If you see, the double row have statistically significant lower retear rate with longer surgical time and higher implant expenses, despite no difference in clinical outcome. Okay. So this is the summary of a comparison between the single row and double row. If you see the pictures here, the A is the single row repair and B is the double row repair. And the most the main differences is the repair rate, whereas double row has a lower repair rate compared to single row, and also better ROM. But functionally wise is equal, and the pain and also the healing outcome, they are both the same. There are other methods of rotator repair, but each have its own pro and cons. But the best is still double row if the surgeon is good in that area. So lastly, about the complication of rotator cuff repair. One of the main cause of recurrent pain is the repair failure or retear. And when that happens, you need to consider either revision or reverse total shoulder arthroplasty. And the risk factors of all these complication retear includes age more than 65 years old, massive tear of more than 5 cm, muscle atrophy with a lot of fatty tissue, and diabetic and also smoker, and when the patient is having poor compliance to the rehabilitation protocol. So these are the things you need to consider when you embark on rotator cuff repair. And also Other complication includes deltoid detachment, especially in open approach, which are rarely done now, and acromial clavicular joint pain, axillary nerve injury, suprascapular nerve injury, and also infection and pneumothorax, which are very rare. So, yeah, any questions?
Oh, thank you, Kow, for the nice presentation. Any question from the floor? So basically, we have previously mentioned, right? Rotator cuff tear, they involve 4 pathology. One is the impingement, second is your rotator cuff tear, third is your pain can be due to the Longhead bicep tendon inflammation, as well as your most of the patient come with concomitant AC joint arthritis. So you have the continuum of disease as explained by Kow just now, right? And then you have, when the patient come to you, you need to address these 4 symptoms, in terms of symptoms and physical examinations. So physical examination, I taught you how to elicit these 4 pathologies, kan? Semua clear about that?
Yes, boss.
Okay, and then in terms of grading, you can grade it through clinical examinations, and you can grade it through MRI or ultrasound. Clinical examination, of course, you need to assess these 4 pathologies, the impingement signs, and then the bicep tendons, the rotator cuff. You need to determine either this is just tendinopathy or partial tear, or even in a complete tear based on the power of the muscle or tendon. You need to examine all those 4 muscles, and then not to forget about your AC joint arthritis, because there's a procedure done in a similar setting where you resect the AC joints, right? Or Mumford procedure.
Okay.
And then, of course, imaging will help you determine the status of your glenohumeral, because sometimes patients with massive tear, they come with glenohumeral arthritis. So the management is totally different, because let's say if massive tear, glenohumeral arthritis, you can't repair the muscle or you can't repair the tendon. You need to go for reverse shoulder replacement, let's say if the pain is unbearable. Other information you can get from the x-ray, you can see the erosion underneath your acromion, and sometimes you can see a bone spur. Sometimes you can see the calcification at the incision of your rotator cuff tendon. Ultrasound is very cheap. You can do in a clinical setting. MRI, of course, is better visualization of the tendon. You can see the tear pattern, and then you can assess the quality of the muscles. And then, of course, most of the time we start with physiotherapy of patient. If patient improve with physiotherapy, then we continue with the physiotherapy. But if you fail the conservative management, you might the patient might require for surgical intervention. Surgical intervention depend. Sometimes patient come with partial tear of the supraspinatus or infraspinatus or even teres minor, but the main thing is because of the impingement. So normally we do arthroscopic subacromial decompression. We debride the partial tear and see the partial tear. Let's say it's a low grade, then we just leave it. Tapi study have shown that within, let's say if you don't do the subacromial decompression, within 2 years, patient might end up with complete tear. From the partial tear, we progress to the complete tear. And then other patients, sometimes even though partial tear is a high grade partial tear, then we convert it into full tear and repair the tear. Massive tear depend on the status of the joint. Let's say supraspinatus massive tear, the quality of the muscle is still good, the glenohumeral is intact, there is no arthritis, then there's an option of tendon transfer using a latissimus dorsi, and some center use this lower pectoralis, lower teres, lower, I think the teres major.
Teres major.
Teres major transfer. And then anterior subscap, we can use pectoralis major. And in case of glomeruloarthritis, with deltoid is intact, and then there's a room for, always we do a reverse shoulder replacement. Satu is to reduce the pain. Second is to allow the patient able to elevate the shoulder. Because biomechanics of reverse shoulder, dia akan replace your rotator cuff punya function. Okay. The other thing, I think that's the most important in rotator cuff. So the type of tear you need to know, and then how to convert during your repair. I mentioned just now separation between your supraspinatus and infraspinatus untuk mobilization kan quite important. Subscapularis tear, need to be repaired, otherwise the symptom is, tapi a bit difficult as compared to others lah. Yang lain of course, yang lain tak ada apa. So rehab post repair, let's say if you repair the rotator cuff, you need to put patient on brace for at least 6 weeks, and then after that you start mobilization after the 6 weeks. You need to allow the tendon to be healed on the footprint before you start active physio. But let's say that you just do a subacromial compression, the tendon is okay, then after 2 weeks you can mobilize the patient, or even the patient feel more comfortable after the operation few days, you can already mobilize the patient by doing a pendulum exercise. But within 2 weeks, selalunya most of the time I allow the patient to abduct up to 90 degree. After 2 weeks, you can do full active range of motion. Yeah, that's all.
But for rotator cuff repair, after you repair, you put on brace for 6 weeks. During that 6 weeks, do you allow any range of movement or just pendulum exercise only?
Depend on intraoperative. If we can bring the tendon to the footprint and we secure with double row, so most of my patient I will do a pendulum exercise, but I will limit the active range of motion up to 90 degree. But if in a massive tear, so much retraction medially, and then we need to pull the tendon laterally, I might just put the brace for 6 weeks. Doesn't matter with the stiffness. Once the tendon heal completely at the footprint, then after 6 weeks we can start with the range of motion. Because we worried about the tear of the tendon once you repair. Depend on the quality of the tendon and how do you repair post-operatively.
And then after the repair,
in a France group, they just put the patient brace for 6 weeks, and they allow for stiffness. After that, that's better for patient. And then after that, they will go all out for physio after 6 weeks.
Okay, so after repair, the most important thing is to prevent any re-tear. So
yes,
you can allow a little bit of stiffness, but you can address it later.
Yes. Okay.
And then when you put the patient on brace, do you put in 30-degree abduction and slight flexion? Or
most of the time I use
position?
Abduction brace. Yes, abduction brace to relax the tendon. Yes, abduction brace to relax the tendon.
Abduction brace, okay.
That company have their own brace lah. It's quite comfortable. Okay. Any question?
Boss, I got a few questions. Boss, boss, first nak tanya is corticosteroid is a part of conservative management, because some studies said the steroid actually can weaken the rotator cuff. Is it we can apply steroid or just analgesic or does not improve with physio, then we go for surgery or not? Is it steroid come in part of the conservative?
Yes, steroid is part of the conservative because you inject the subacromial steroid as well as local anesthetic. Patient will immediately improve after that. But however, the risk of if you inject the steroid inside the tendon, you weaken the tendon. And during my fellowship in Liverpool, with Prof. Frostic, he actually banned the steroid injection.
Oh, okay.
But here in UIA, I select my patient for injection lah. If the patient doesn't want any operation and patient in great and severely pain, and if involved bilateral shoulder, I might offer for injection. Otherwise, most of my patient you saw in clinic, I just send for physio, and if not improved, then we go for arthroscopic subacromial decompression. That's the deal. I select my patient, not all I send for injection.
Injection.
Yeah.
Okay, boss. Thank you, boss. Boss, there's another question. During subacromial decompression, is it a routine to release the coracoacromial ligament?
Yes. My practice, I do release the coracoacromial ligament because sometimes I find it difficult to reach the anterior part of your anterolateral part of your acromion, which cause impingement. So I release partial near to the incision underneath your acromion. So that I really can shave underneath of the acromion.
Okay, but
Longhead bicep tendon in older patient, most of the time I do tenotomy. But seldom I cut the longhead bicep tendon. But in younger patient, you might need to tenodize. Tenodesis of the longhead bicep tendon.
Okay, boss. Boss, post-release coracoacromial ligament, is there any incidence of superior migration of the humeral head?
No. In my case, so far there is no patient. None of the patient having problem with superior escape of humeral head.
Okay, boss. Boss, just one last question. Sometimes patients present with a massive rotator cuff tear. They come with a pseudo paralysis, and sometimes they present as a brachial plexus injury also. Is there any test which can differentiate whether is it caused from rotator cuff or is going towards a brachial plexus like that?
No, most of the time when you check this type of patient, they have a massive tear of the rotator cuff. So of course you need to examine the neurology. Examine the neurology, and they are unable. They are unable to abduct up to initiate the abduction, right? But when you lift up the shoulder more than 90 degrees, actually patient able to actively elevate the shoulder. That's the meaning of pseudoparalysis. Brachial plexus is different entity. It's a pathology from your nerve pathology kan. So you must assess your brachial plexus properly. Okay, I've got I've got patient. Nanti kita sambung balik the lecture. Boleh?
Okay, sure, boss. Thank you, boss.
Okay. Nanti kita sambung balik. Okay, kau ni record kan kau?
Ada.
Okay, sebab nanti I nak share in my
sure, boss.
okay, thank you.